Alright, this episode's going to upset some people. Good. You've been given a label: depression, anxiety, ADHD, something from a catalog. The label came from a book called the DSM for short, or the Diagnostic and Statistical Manual, published by the American Psychiatric Association. It's the operating manual for what counts as normal and what gets flagged as disordered. But here's the engineering question nobody asks. Who designed the spec for normal? And what if the spec itself is flawed? So let me walk you through the evolution of this thing, because it didn't emerge from rigorous neuroscience. Before the DSM, and earlier in mental health care, we had asylums. People locked in institutions. They got ice baths, insulin shock treatments, early electrical shock treatment, and the Thorazine shuffle was coined from patients chemically sedated into compliance, shuffling down hallways like zombies. That was the system in the 60s. So the American Psychiatric Association started asking a reasonable question. Can we standardize this? Can we build a classification system for mental illness? And that impulse to systematize, to create a shared framework, that's a legitimate engineering goal. But here's what's happening simultaneously. Professions need legitimacy. Psychiatrists needed to say, we are a medical specialty, we treat disorders, and here's our diagnostic manual. Standardization, professional identity, a taxonomy. The people building this taxonomy, many of them guardian temperaments, were rationals. The guardians are methodical, protocol-driven, consensus-oriented. Nothing wrong with that approach, unless the methodology has a systematic bias baked in. So then we have the 1980s, several variables changing at once. The first, Willowbrook. Geraldo Rivera's big breakthrough was releasing this story. It was about a state institution for children with intellectual disabilities in upstate New York. The conditions were so horrific, they made national news. Deinstitutionalization begins then. More patients are moving into communities. And around those times, there's new ECT guidelines for a, humane and consistent procedure for this. Because in the past, electrocuting someone's brain without consent wasn't really the treatment. So they're making progress, actual progress. The DSM keeps getting revised, not because of neurological breakthroughs, because of cultural recalibration. Homosexuality, classified as a mental disorder until 1973. They didn't discover a new brain structure that year. Activists push. The culture shifted. The classification is what changed. One day, disordered. Next day, not. Then there's kink in BDSM. Pathologically determined to be a disorder for decades. DSM-5 in 2013 updated the criteria. Kink is only a disorder if it causes distress or harm. The behavior didn't change. The classification changed. See the pattern? The DSM isn't measuring brain pathology. It's measuring cultural deviation. So, disorder means too far from what the dominant group considers acceptable. That's not science. That's sociology with a medical label. But the 80s introduced yet another variable. Prozac. The Prozac revolution created a massive new market. Psychopharmacology became a billion-dollar industry almost overnight. Drug trials, research funding, and the DSM became something it was never architected to be. It became the inclusion criteria for pharmaceutical studies. Here's the interesting part of this. To run a drug trial, you need a defined study population. Money. The DSM provides the filter. These symptoms, you qualify. These symptoms, you don't. So the diagnostic manual starts optimizing for what's observable, measurable, quantifiable. Can you see it from the outside? Can you check a box? Can you run it through a statistical model? That's good empirical methodology, don't get me wrong. But what fails outside the model? The subjective experience of the people. What's it like to be the person in the chair? What's the internal architecture? What's the nervous system state? What are the belief structures running below conscious awareness? Everything that matters most is excluded from that measurement framework. So we have a lens problem. And meanwhile, outside of psychopharmacology, cognitive behavioral therapy takes over the therapeutic landscape. CBT. Makes sense? Modify the thought, modify the feeling. There's measurable outcomes, short-term protocols, insurance friendly. And here's the part that should bother you. The clinicians who author the DSM, the most published, the most funded, the most influential voices in the field, some of them have financial relationships with pharmaceutical companies, which they have to disclose now when speaking, but they get consulting fees, speaking engagements, research funding. Not saying all of them. Many clinicians genuinely care about their patients. I mean, even the ones making money might care too, but when people who are defining the disorders have financial incentives tied to the treatment of those disorders, that's a corrupted feedback loop. And systems thinkers can see it. It's like letting the fox write the henhouse building codes. So let's look back. I was trained on DSM-3. DSM-4 came out during my career, and then the DSM-5. In my 25 years of nursing, 3 different editions, each one different, each one reflecting the profession's consensus at that point in time. And I was always an unusual clinician. My brain naturally wanted to see the underlying architecture, the patterns beneath the systems, what my patients were experiencing on the inside. Now, I used the DSM, and there was what I could observe and categorize from the outside. The DSM could capture what was measurable, observable, compatible with the empirical method. But sitting across from a human being in crisis, I guess the art of medicine, the checklist doesn't model that. So here's what I'm doing. I'm not discarding the DSM. It's the framework we've had. Good clinicians have used it responsibly, and it also created a shared diagnostic language for everyone. But I'm looking at the lens, changing the lens. The DSM asks, here's society's standard. Why don't you meet it? I'm asking, what is the internal experience of the person who is struggling to navigate this system? Because if you get to the root causes and then you analyze it from the patient's perspective, from the inside, you get more effective interventions, different interventions. If you analyze it from the institution's perspective, you get more murky because the institution has financial incentives embedded in the solution architecture. And the patient becomes a data point in someone else's revenue model. That's the analytical frame for everything we discuss here. Not what's wrong with you, but what's actually happening inside you. And what does the system need to look like to address it? So who decides normal anyway? Here's the data. The guardian temperament. SJ types. They make up roughly 40 to 50% of the population. They're the largest group. Guardian values like tradition, stability, rules, conformity, established procedures. Statistically, normal just means what most people do. Abnormal means statistical outlier. But outliers in the DSM get pathologized. It's a hard word to say. Forgive me. So basically, if you're not in the fat part of the bell curve, you get a diagnosis. Cool system. Is the person malfunctioning? Or is the system just not designed for that type of processor? So, let's look at depression. The legacy model. Chemical imbalance in the brain. Medication corrects the imbalance. Implication, your hardware is defective. But what does polyvagal theory actually show? Depression is often dorsal vagal shutdown. The nervous system calculated the threat level exceeds the capacity. Fight won't work, flight won't work, therefore shut down. That's not a malfunction, that's an adaptive response. Your nervous system isn't broken. It ran the threat assessment and executed the best available protocol, unconsciously. In an overwhelming environment, shutdown actually is strategic. The disorder is actually your body's risk management system working as designed. Same architecture with anxiety. There are diagnoses: generalized anxiety disorder, social anxiety disorder, panic disorder. I treated a lot of people with these. But the translation from every one of those, your brain is defective, here's a chemical patch. Now what's actually happening? Your sympathetic nervous system activated. It was running on top of encoded threat beliefs, such as I'm not safe, I'm not competent, the system will fail. The nervous system is executing its primary function, threat detection. It's not malfunctioning, it was trained on bad data. So anxiety is a signal, not noise. The signal says, something in this environment reads as unsafe. Medicating the signal without debugging the cause? That's turning off the warning light on the dashboard instead of checking the engine. Then there's other diagnoses: ADHD, autism spectrum, personality disorders. Increasingly recognized as cognitive architecture variations. But let's look at it from another lens, not defective hardware. Neuroatypical people. ADHD, different attention allocation system. And the name doesn't really do it justice. Listen to Russell Barkley if you have ADHD. He'll tell you. Anyway, ADHD, possibly optimized for different environments. Disorder only in a system that demands sustained linear focus. And there's autism. That's really different processing architecture, social data, sensory data, pattern recognition, all handled differently than typical brains. Disorder only when the environment demands neurotypical performance. It's an asset when the task demands deep focus and precision. So something different, personality disorders, but let's look at those through a different lens. They're typically developmental adaptation to an insecure attachment in childhood. They never learned emotional regulation. So disordered? Or are they running a survival code that became rigid? And they can't have relationships without difficulty now. So the question isn't what's wrong with this component. It's what system was this component designed to operate in? I need to give you some primary data. I was inside the system for over 25 years. Psychiatric nurse, then a prescriber. I diagnosed people, thousands of patients over the years. I analyzed the patterns, saw how nervous systems responded. I was trained in their protocols, I attended their conferences, and I saw systemic groupthink, confirmation bias everywhere. When I once challenged the diagnostic framework around attachment disorders, I tried to integrate what I was actually observing with a trauma model. My supervisor publicly humiliated me and shut me down. So that's the system's immune response to internal criticism. So when I tell you the mental health system is experiencing structural failure, this isn't theoretical. I was inside the machine. I walked away from it. Demand exceeding capacity everywhere. Therapist burnout. Prescriber burnout. I've got a video on this. Private equity acquiring practices. High deductible insurance models. 6-month wait times. 15-minute medication management replacing actual treatment where the patient gets to say something. The incentive structure. Pharmaceutical companies profit from lifelong prescriptions. Insurance companies profit from claim denial. Corporate mental health profits from patient volume. Nobody's business model includes patient gets better and leaves. So root causes never get addressed. Symptoms get managed indefinitely. Revenue maintained. So what's the intervention? Individual level. Competent therapists still exist. Locate one if you need one. Medication can serve as stabilization. Most are a temporary scaffold, not a solution. There's some cool meds that might actually help rewire the brain. Nervous system practices from episode 9. Shadow work. Audit your own programming. Co-regulation. Find safe humans. And then the systems level. Mass individuation. Not just individual optimization. Collective debugging. Identify the collective shadow, as Jung called it. We're in consumer culture. We're disconnected. There's inequality everywhere. Intergenerational trauma propagation. A lot of work to do. Then the generational level. Secure attachment parenting. Again, one generation can interrupt the transmission chain of the intergenerational trauma and raise healthy children. So one generation of securely attached children restructures everything downstream. So here's the conclusion. You are not necessarily just disordered. That's a certain language choice. And language depends on what lens you're looking at things through. More accurately, for my lens, you're executing a normal response to an abnormal input environment. Your nervous system is running the program it was given. Your symptoms are diagnostic signals, not evidence of defective hardware. The actual disorder? A society that's lost coherence. Intergenerational trauma running unchecked. Environments that destabilize nervous systems by design. And a system that profits from your dysfunction. So we finished Phase B, 2B. How civilization broke us. We'll be starting Phase 2C, incoming. The way out. Actual protocols. Integration architecture. System redesign. You're not broken, not disordered. You're a complex system responding to environmental inputs that weren't optimized for human function. That's a solvable problem. I'll see you next time.